All right, let's dive right in. As clinical psychopharmacologists, we know that when a behavioral emergency hits the ER, the clock doesn't just tick, it accelerates. We are jumping immediately into a high-velocity clinical breakdown. Today's explainer is all about rapid error mitigation and mastering kinetic protocols. We're stripping away the noise to look strictly at the raw data and targeted receptor mechanics that literally save lives. Here's our cognitive map for today. Module 1, hyperthermia, specifically serotonin syndrome versus NMS. 2, lithium toxicity and dialysis. 3, extrapyramidal progression timelines. And finally 4, clinical crisis reconciliation. Let's get to it.
Starting with Module 1, hyperthermia. This is your first major pathophysiological fork in the road. When a psychiatric patient presents with a fever cooking their brain, you've got minutes to figure out exactly which receptor pathway has failed.
Let's isolate the neuromuscular differentiators. Both toxidromes present with extreme hyperthermia and altered mental status. But look at the physiological contrast. Serotonin syndrome is driven by 5-HT overstimulation. It's a state of hyperkinesis. You'll see hyperreflexia and spontaneous neuromuscular clonus. That bouncing is absolutely your most sensitive sign. NMS, on the other hand, is driven by severe central D2 receptor antagonism. The hallmark? Generalized severe lead pipe rigidity and hyperreflexia. This brilliantly illustrates exactly what we're talking about. We've got a 73-year-old woman on risperidone, a high-potency antipsychotic. She's brought in confused, temp is 103, muscle rigidity everywhere, and her creatine kinase is spiked to 2,000. That CK level is screaming prolonged muscle breakdown. The immediate, absolute first step, stop the offending agent. Once you've stopped the drug, you map specific reversal agents strictly to their receptor deficits. For the 5-HT overstimulation in serotonin syndrome, your antagonist is cyproheptadine plus IV benzos for agitation. But for the D2 blockade of NMS, you need dantrolene to halt sarcoplasmic calcium release and break the rigidity, or you reach for a direct dopamine agonist like bromocriptine. Now, pay attention to what I call the pyrexia trap. You see a temp of 104, your reflex is to push Tylenol. Stop right there. Standard antipyretics like acetaminophen are completely useless here. The hyperthermia in NMS isn't a changed hypothalamic set point. It's kinetic heat driven by relentless peripheral muscle contraction. Pushing acetaminophen is a lethal decoy. To resolve this, you rely on strict choice architecture. The execution sequence is 1. Stop offending agents instantly. 2. Aggressive IV fluid resuscitation to protect the kidneys from circulating myoglobin. 3. Dantrolene titration. Do not get distracted by empiric cooling decoys. Moving to Module 2, lithium toxicity and dialysis. We're shifting gears from receptor kinetics to renal clearance kinetics. Lithium is a brilliant drug, but its therapeutic window is terrifyingly narrow. Let's look at the hemodialysis execution matrix. Lithium is entirely renally cleared, basically mimicking sodium in the proximal tubule. Look at these strict red lines for emergency dialysis. If you've got an absolute serum lithium level over 4.0 or over 2.5 coupled with severe neurodeficits, acute kidney injury, or hemodynamic instability, you pull the trigger on hemodialysis. No exceptions. Here's a massive clinical variance box. If a patient is toxic on lithium, never ever give them a thiazide or loop diuretic. Because lithium mimics sodium, a thiazide decreases GFR and actually increases proximal reabsorption. You force the kidneys to hold on to more lithium, massively worsening the toxicity. It's a fatal iatrogenic error. So, a chronic bipolar patient rolls in. Slurred speech, creatinine 2.4, lithium level 2.8. What's the protocol? Assess the neurodeficits first. Look for coarse tremors or ataxia. Initiate aggressive volume expansion with IV normal saline to maximize renal sodium delivery and force lithium excretion. And crucially, map them for emergent hemodialysis. You don't just put them on maintenance fluids and wait. Module 3, extrapyramidal progression timelines. Let's go deep into dopamine D2 antagonism in the nigrostriatal pathway. When antipsychotics disrupt that basal ganglia motor loop, extrapyramidal syndromes, or EPS, emerge. What's fascinating is the strict timeline architecture here. EPS is not random. It is highly predictable. Hours to days, acute dystonia. Days to weeks, akathisia, that agonizing motor restlessness. Weeks to months, drug-induced Parkinsonism. And months to years, tardive dyskinesia with those involuntary chorioathetoid movements. Memorize these windows. Let's anchor into that first hours to days window. Imagine a schizophrenic patient, 48 hours after starting haloperidol, developing sudden, intensely painful muscle contractions. Maybe torticollis, where the neck twists, or an oculogeric crisis, where their eyes deviate upward. Choice architecture forces immediate action. Match the syndrome to its precise antagonist. Dystonia, IV benzotropine, or diphenhydramine restores that dopamine acetylcholine balance. Motor restlessness of akathisia, first line, beta blocker, propranolol. Parkinsonism gets amantadine or benzotropine. But tardive dyskinesia? Discontinue the agent, switch to clozapine, or add a VMAT2 inhibitor, like valbenzine.
But watch out for this trap. Anticholinergics like benzotropine are great for early EPS, like dystonia. But if you give benzotropine for tardive dyskinesia, which happens months to years out from receptor upregulation, you will literally worsen their involuntary movements. Isolate the timeline, then pick the tool.
Module 4. Clinical Crisis Reconciliation. In the ER, things don't happen in textbook chapters. They overlap. It's time to integrate these variables for rapid error mitigation. Let's run a scenario. Highly agitated patient, unknown neuroleptic history, mixed hyperthermic neuromuscular clonus, and severe electrolyte failures. What's the sequence? First, force IV benzos for cooling and agitation. Bypass Tylenol entirely. Observe the clonus. That points away from NMS directly to serotonin syndrome. Meanwhile, run your lithium panels to rule out renal failure. Sequence the benzos and panels over blind interventions. Ultimately, mastery is choice architecture. You have to sequence raw kinetics and target receptors with absolute precision. Knowing lead pipe rigidity from hyperreflexic clonus, or exactly when dialysis trumps fluids, is the difference between a good clinician and a great one. So ask yourself, if that patient crashes through your doors right now, are you ready to execute? Keep mastering the pathways, and I'll catch you in the next explainer.